Welcome, 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 welcome. My name is Anton Gunn, and thank you for joining us today. I'm an advisor to the Intersection, a Robert Wood Johnson initiative with a focus on leaders in advocacy and healthcare. And I want to extend a warm welcome to everyone that is joining us today. See, the Intersection is a place to convene, to learn, to share resources, and discuss what organizations are doing to build anti-racist health systems. This is a community that encourages collaboration and provides opportunities that go beneath the surface to learn from both successes and challenges and to sharpen strategies and your efforts. Please check us out at meetattheintersection.org to access recordings of previous conversations, resources from the Robert Wood Johnson Foundation grantees, short videos from equity leaders. You'll find a wide range of helpful resources on the website. There's also a podcast called The Intersection, where healthcare and anti-racism meet, which is available on all streaming platforms wherever you like to get podcasts. And if you're not following The Intersection's LinkedIn page, please do so now. You can connect with others, stay up to date on future events and resources. Now, before we get started, I'm going to turn it over to Imani Samuels to lead us in a grounding. Imani?
Thank you, Anton. We gather today in shared recognition that something sacred is at stake. This is about more than Medicaid. This is about dignity. It's about protecting the humanity of our neighbors who are already navigating the edges of a frayed system. This conversation is not abstract. The harm is real. And behind every statistic is a person trying to be well. So I invite you to arrive. And if it feels safe, just let your shoulders fall. Unclench your jaw by opening your mouth and just allowing it to relax. Releasing any tension, refuting any urgency you may feel. Let your breath deepen and soften. Inhale for a count of 4. And exhale for a count of 8. Opening your thoracic lungs. This moment belongs to you, to the advocates, caseworkers, researchers, organizers, policy leaders, Medicaid enrollees, state employees, educators, community partners, and you. You have entered this space for a reason, and your presence matters. Some of you are here today to learn. Some of you are here to grieve, to share, to reimagine, to restore. And for that, we honor you. As we listen, speak, and reflect today, may we remember this work is bigger than any one of us, but not beyond all of us. You are needed. You are not alone. Together, we can preserve what matters. Let us begin.
Thank you, Imani. I really appreciate you getting us grounded for the conversation that we're going to have today. The Medicaid program has helped the lower and middle class income people access health insurance coverage in the United States for more than 60 years. Now, all of that is about to change. See, changes in the one big beautiful bill, quote unquote, passed early this year are expected to cause millions of people to lose Medicaid coverage over the next decade. And before we dive into strategies to preserve as much coverage as possible, we think it's important to have a little bit of history about Medicaid, a history lesson. Yes, it's an important component of our healthcare coverage system for people who are low income. We know that. But the program is also riddled with systemic racism back to its initial founding. So I'm pleased to welcome Dr. Jamila Michener to give us some historical context on this. She's an associate professor of government and public policy at Cornell University, the director of the Center for Racial Justice and Equitable Futures, and a senior associate dean for public engagement at the Brooks School of Public Policy. Jamila, thank you so much for being here today to join us for this discussion at the intersection and providing us with some insights into the history of Medicaid and the impending legislative changes. I'll turn it over to you.
Anton, thank you so much. I appreciate that welcome and that broader contextualization that Medicaid is important and that it matters for a lot of people in really profound ways, but that it also has some challenges that have been embedded from the very beginning that are worth noting because they reflect on the present moment and where we are in this moment. I'm just going to take a few minutes to ground us in some of that history and bring us to the contemporary moment and the implications of that. And then I'm excited for the conversation to unfold with the incredible folks that we have here today. Next slide, please. I have a few slides for you all. I promise you that it won't be too much. I'm going to focus on Medicaid through the lens of structural racism, both in the past and in the present. And one might ask, why? Of all the things to focus on, would we focus on that? And the way that I think about Medicaid, both the policy as it's written and the practice as it's implemented and administered and experienced by people, is that it is sitting atop a structure, right? So when we say structural, it's like, what does that mean? Medicaid is sitting on top of structure, and that structure consists of laws, rules, ways of thinking and understanding the world, right? Ideologies, norms, things that we do that we take for granted, narratives, the way that what makes sense to us, the way we talk, the way that we, the kind of the ether that we live in and take for granted. All of those things are part of a structure. And that structure is part and parcel of our economic, political, and social systems, right? Those laws, rules, ideologies, norms, they pervade all of the systems, right? That determine and that shape our lives. And those things are at the base, and Medicaid sits on top. And without understanding that base, and how it ends up being refracted and reflected through Medicaid, we lose the opportunity to understand crucial things about the program. Next slide, Pete, please. One of the ways that people tend to think about Medicaid when we think about Medicaid and racism is in a kind of like statistical demographic way, right? And if you look at this map, that makes sense. Look at those dark kind of burgundy red states like Florida, Texas, Oklahoma, California, North Carolina. Those are states where over 50% of people who rely on Medicaid, of Medicaid beneficiaries, are people of color, Black, Latinx, Indigenous, or multiracial, right? And then there's another tranche of states that kind of pinkish color like Arkansas, Kansas, Missouri, where 30 to 49% of Medicaid beneficiaries are people of color. And so you can see that in most states, a large portion of Medicaid beneficiaries are people of color. And one can say, oh, this is why structural racism is implied in Medicaid, because it has disproportionate implications for people of color. And while that's true, it really is only the tip of the iceberg. Next slide, please. Because it's not just about basic demographics. It really is about a history around how Medicaid as a program was designed from the very beginning. And it was designed in ways that amplify and create opportunities for the racism that was already built into the systems in this country to be perpetuated, right? So if we go back a little bit and we put Medicaid in its context, it was passed in July 1965, just a few weeks after the Voting Rights Act and less than a year before the Civil Rights Act. So we're getting Medicaid in the midst of the civil rights era and in the wake of and preceding really foundational legislation that really laid the groundwork for civil rights and whatever, progress towards racial equality that we saw during this time, right? But even as a policy passed during this watershed moment, Medicaid's design actually inscribed racial inequality, whether intentional or not, right? So let's think about how. First of all, Medicaid was modeled on a program that already exists, a program that was known as Kerr-Mills, and that program was tethered to cash assistance programs, or what was known as welfare programs. And those welfare programs were already racially stigmatized, were already very different in different states, and were already distinct in terms of how they were implemented, for example, in the South, in ways that prevented Black and Brown people from being able to access them at the same levels as white Americans. And so we had a program or a set of programs that we call welfare programs that were already racialized and unequal. And we tethered Medicaid to those programs. We modeled it after a program that was tethered to those programs. And one of the things that this precursor to Medicaid was known for was large gaps in terms of access, particularly that Black populations and especially Black populations in the South had. So we had this program called Kerr-Mills. We were well aware that Black people, particularly Black people in the South, had very limited access to Kerr-Mills, but we built Medicaid on top of that program, right? And so, yes, from the very beginning, many of the limits of this precursor program carried right over into Medicaid. And Medicare, our program for older Americans, 65 and older, was passed at the same time. But that was a program that was not income-based and that was going to disproportionately be benefiting white Americans. And it was centralized at the federal level, and it was funded in a way that was sustainable and not contingent on appropriations processes or in the same way or on state choices. But that's not what we did for Medicaid, the program that was for low-income people and that we knew would disproportionately be helping people of color. Instead, for that program, we made it optional. States could opt in, and we gave states immense discretion over how they designed it, who was eligible, and how they administered it. People have even called Medicaid the quote unquote friendless stepchild of Medicare. And so we took the program that was going to be for the more marginalized, economically and racially marginalized groups, and we designed it in a way that was going to create a two-tier system that would give folks less access. And there were some states, even though Medicaid was passed in 1965, that took years to opt in. North Carolina didn't opt in until 1970. Alaska waited until 72. Arizona waited all the way until 82. Next slide, please. So this is the history, right? We're building on a program that was racialized, and we're building a further racialized program now that's even bigger, right? Next slide, please. That has translated into the contemporary moment. And we have all of this evidence to suggest that the way that people understand and respond to health policy, and Medicaid specifically, is based on race, right? That how people evaluate the ACA, the Affordable Care Act, really changes when they associate it with President Obama, a Black president, that we see less racial sympathy and more racial resentment. Those sentiments lead to higher levels of resistance to Medicaid expansion. White Americans are less likely to support Medicaid expansion, and their opinions are the opinions that tend to affect adoption decisions. And when governors expand Medicaid in places where Medicaid populations are whiter, they are more rewarded politically in the next election. So these are just a few things that really point us to not only the historical, but the contemporary ways that racism continues to operate with respect to Medicaid policy. Next slide, please. And I think this is my last one. I don't want to wrap up without pointing out that these things have real implications for the lived experiences of Medicaid beneficiaries, right? This is a quote from a woman who's featured in my book and who I interviewed years ago, but I've talked to hundreds of people in the time since who have said similar things. She said, if you're white and you have Medicaid, you're looked at with more sympathy, right? It's like you're going through a hard time. But if you're Black, right, African Americans, we're looking for a handout. We must be uneducated and so forth. So there are stereotypes and there are ideas, like I said, those structures, the norms, the practices, the policies that we've seen from the beginning that follow through contemporarily and that emerge in how people experience these programs. And that's the history, that's the backdrop that the rest of this conversation is embedded in. Thanks, everyone.
Wow. Well, thank you, Jamila, for that breakdown. I mean, you broke it down and forever let it be broke, that this is important context for us to take into our discussion. So thank you so very much for enlightening us. And now I want to get to the meat and potatoes of what we're going to talk about with our panels. But before I do our panel introductions and welcome them into the room, I have a couple of housekeeping items that I want to make everyone aware of. So if you have a question, please add your questions into the chat throughout this discussion. We'll record a podcast after today's panel based on your questions and some of the themes in the conversation that we have today. So don't forget to drop your questions into the chat. And we also will hope that you will stay for our small breakouts after the panel discussion. So we want to continue this discussion with you in the breakouts and allow you the opportunity to meet others that are doing this work. So if you plan to stay for the breakouts and you need to be in the room with an ASL interpreter, please send a private chat right now to event support. You'll see event support right there. So if you plan to stay for the breakouts and you need to be in a room with an ASL interpreter, please send a private chat right now to event support. Okay, let's get started. And I'm excited to introduce an incredible panel of leaders, each offering a very different perspective throughout their work in advocacy, policy work, and in communities to help improve health equity. Now, first, we have with us Laura Colbert, who is the Executive Director of Georgians for a Healthy Future. See, Medicaid work requirements went into effect in Georgia in mid-2023, and her organization has been working on multiple fronts to help people to stay covered throughout this time. Our next panelist is Stan Dorn. He is the Health Policy Director for UnidosUS, the nation's largest Latino civil rights and advocacy organization, and he helps lead a collaboration to protect Medicaid against various threats. And we also have Jennifer Flynn Walker, who's the co-chief of campaigns at Popular Democracy. She is the founder and former executive director of Voices of Community Activists and Leaders, where she organized and advocated for people without homes, immigrants, and many others. And lastly, but definitely not least, is Deanna Williams, and she's the Central Georgia Enrollment Assister at Georgians for a Healthy Future. Laura's organization is where Deanna works, and Deanna provides enrollment assistance, community outreach, and education. She is at the tip of the spear on the ground, helping people through this tough challenge. So I want to thank you all for joining us today. And Stan, I'm actually going to start with you. And this question is kind of twofold. So can you share how will these administrative burdens work? Like, how does this documentation affect people on Medicaid, including people who've already met the work requirements by working or volunteering or serving as full-time caregivers? Can you give us some sense around these burdens and what they might mean and how they might affect people on Medicaid?
Yeah, absolutely, Anton. And it's just a real honor to be with this amazing panel today and to be with all of you who are listening and hopefully commenting in the chat. The so-called big, beautiful bill that the president signed into law on Independence Day, one of its recurring themes is it terminates benefits for people by putting paperwork burdens on families that are already overwhelmed and under-resourced. And we know that when you do that, lots of folks who are eligible, who are guaranteed benefits under federal law, just don't get the benefits. So in the Medicaid space, what that means is if you don't document that you're working or you don't document that you are have a good reason not to work because you have a disability, you're caring for somebody who's a minor child, you're an aging parent, etc. If you don't document one of those things, you're terminated. And that's just one example. Another example, people who are covered as Medicaid expansion adults have to recertify their eligibility every 6 months, even if there's no evidence of ineligibility. If they come in and fill out the paperwork. And we know that when you put paperwork burdens on people, lots of folks who are eligible don't wind up completing the paperwork. So, for example, research shows us that, and there's racially disparate effects of these paperwork burdens. Research shows us that that 40% of non-Hispanic whites who are terminated from Medicaid routinely are actually eligible, but are terminated just because of paperwork. That's terrible. For African Americans, it's 48%. For Latinos, it's 52%. In other words, most of the people who are routinely terminated were Latino, African American. At least half are actually eligible, but terminated because of nothing but paperwork and bureaucracy. So here's how it works out in the work requirement space. We know Georgia is currently, as Anton said, the only state that's doing this policy, but Arkansas did it a few years ago and got a lot of study. And we found that more than 90% of everybody who was terminated was either working or had a disability or was otherwise exempt from working requirements because of people that they were caring for. So there were tens of thousands of people who lost Medicaid, even though they met the requirements or were exempt from the requirements. How could this happen? People didn't know about it. People got a notice and they didn't understand what the heck that gobbledygook meant. They didn't get the notice. They moved. They couldn't speak the language. They got the notice and they tried to fill out the form. They thought they filled it out. The state said they lost it. They went online. They couldn't access online. They were on the wrong side of the digital divide. They picked up the phone and called to try to reach the call center. Long waits, calls dropped, couldn't get clear information from the state. Any of you on this call who's dealt with these horribly underfunded state agencies knows the millions of ways that people fall through the cracks who ought to qualify just because of the paperwork and the bureaucracy. And I think this really goes right back to what the professor was telling us earlier about racism and, the systemic racism. The system is set up to fail, and it's set up to fail certain people more than others. I'll close with just one example. Our Florida office has looked at the call center that serves Medicaid beneficiaries, and they've done secret shopper surveys. They found if you call on the English language line, on average, you'll get through in, 10, 15 minutes, rarely dropped. If you call on the Spanish language line, the vast majority of the time, the call is dropped. And when it's not dropped, it takes you up to an hour. The average is like 45, 50 minutes to get through. Guess which group of people is going to be most dropped because of Medicaid work documentation requirements? I don't think you need a PhD to know the answer to that question. So, this is the way the Republicans are working across the board. They're doing this with SNAP. They're doing this with the Affordable Care Act. They're doing with the earned income tax credits. It's really smart politically. You don't have to talk about the paperwork and the bureaucracy. You talk about the underlying purpose. Oh, we just want people to work. Don't you want people to work? Oh, we just want eligible people to be the one. Are you saying you want cheaters to get benefits? But the reality is they know very well it's the paperwork and bureaucracy that's going to knock eligible people off. What comes to what I remember, I'll never forget, Haley Barbour, former chair of the Republican Republican Party, governor of Mississippi, said, well, we're giving people Medicaid benefits worth a few $1,000s. It's not too much to ask them to come down to a social service office, talk to a caseworker and fill out some paperwork. None of that stuff mattered for eligibility, but it's an obstacle course they wanted to set up, knowing that people wouldn't be able to follow through. So I could talk for hours and hours, as you know. I'm gonna stop myself. But thank you for this question.
Yeah, well, that's a great point. And actually, Deanna, I want to bring you into this because you're on the ground right now in Georgia with people signing up for coverage where work requirements have already been implemented. What are some of the things that you're seeing as it relates to signing up and maintaining healthcare coverage?
Okay. For some of the things we've seen and experienced in Georgia, always started with technical and administrative issues and glitches. So we have clients who are trying to complete an application, but they're reporting their system is crashing or data is being lost when they're trying to submit the application online. Along with them trying to get assistance from the local DFACS office, Division of Family and Children Service office. Those offices have limited times. They're open limited days during the week. So some people cannot always get access to get that help. But from some of the complaints I receive working in the field, clients go to get assistance when they're open and they're still turned away. Asked to come in for certain days to complete an application or to put the information in a Dropbox. Here in a rural area, many of my clients may struggle with reliable internet and being able to access the portal on their smartphones or devices. This issue is making digital access hard, and one of the biggest issues is uploading those documents. That's particularly difficult with a lot of my clients. I'll give you an example of that. A client may be asked to upload a document for their qualifying activity or work requirement, but if it is not in the proper format, it will give them an error message, which they cannot upload the document. And if they're not able or not computer literate, that can be an issue because they can't just go and change that format and upload the document. If that document is not received, that can lead to delay in coverage as well as a denial because verification of that document was not received. So most of my clients as an assister, they may reach out to someone like me, but again, everyone does not have someone like me. So they may ask me to upload the document for them, and that is something I'm able to help with. But one of multiple issues that I'm also seeing is the long delay and massive backlogs that we have. I would definitely say early on, the processing time for them to process the application, they say they used to take up to 45 days, but it was taking longer than that for them to get processed.
Wow. 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 Those are real clear and present challenges. If you live in a rural area, lack Wi-Fi access or have a smartphone and, you got an iPhone, but it puts it in one format, but you can only upload it in a PDF or a JPEG. All of those things can be significant challenges. Laura, I want to bring you in to share a little bit from your experience and perspective. What policies or practices in Georgia have helped to troubleshoot these problems that arise, and how could those lessons kind of guide other states? I'm hearing people talk about things in different states in the chat. So give us some sense of, what we can do to help troubleshoot the problems that arise from a policy or practical standpoint.
Absolutely. As you can hear from Deanna, we've had a number of fits and starts here in Georgia. Our work requirement program has been in place for more than 2 years now, and we have less than 10,000 people enrolled statewide. And so it's been quite a struggle to get people to earn that coverage, and not because they're not working. We've had several 100,000 applications and still only 10,000 enrolled. There are a couple practices that we have found that have really helped, and I have a very long list of advice for other states, so I certainly hope we get there. But one thing that has been particularly helpful, especially for enrollment assisters like Deanna, is to have a point of contact at our Medicaid and our eligibility agencies. In Georgia, our eligibility agency is separate from our Medicaid agency. They are sister agencies. And so having a point of contact both in Medicaid and a customer service contact that we can escalate cases to when somebody's application has gotten lost in the system or they've dropped off their documents and they're not showing as part of their application, that kind of thing. So we can escalate it to that customer service contact. It would be particularly helpful in Georgia, and I'm sure in other states, if there was a specific customer service team just for work documentation issues. So hope we get there eventually, but that's been an early help to enrollment assisters like Deanna, and that has certainly helped us troubleshooting and trying to get folks covered. And I'll just add that kind of going back to what Deanna was saying about slow applications, Georgia has among the slowest application processing times in the country. So regularly, more than half of our applications take longer than 45 days. So it's been quite a struggle, and this customer service contact has been helpful.
Wow. Thank you for sharing that. And those are some great lessons and insights to be learned. Jennifer, I want to bring you in. How can we use this opportunity? And I'm going to call it an opportunity because, this is massive challenge. There's a lot of changes coming right now. But how can we use this as an opportunity to strengthen and improve the Medicaid system? Any thoughts you can offer around what can we use this opportunity to make things better?
Yeah, well, we don't have a choice but to try to make things better, and we have to be careful. And the good news is that I'm here to tell you that better times are coming. They might not be coming soon enough, but they are coming. And we have to use the upcoming changes as an opportunity to strengthen and improve Medicaid by approaching them proactively and strategically. And I actually believe that the unpopular attacks on the healthcare system overall are going to usher in those better times. It's going to be a big part of it. But we have to organize each other. We have to organize. If you're a Medicaid recipient, join an organization where people are fighting to save Medicaid. If you are a service provider, invite organizations, organizing groups, and advocacy organizations into your organization to talk to your patients and your consumers and clients, and have them get information about how they can get involved and share their stories. And we have to be surgical right now. So we have to try to preserve the Medicaid program and honestly, the entire social safety net and the Affordable Care Act, because even though Medicaid was built on a system of racism, the system that is trying to tear it down is also racist. And they are actually people who are not trying to help any of our communities. They are trying to harm our communities. And so we need to do everything that we can to save it. But so right now, internal conversations about the improvements, because we need to start talking about that now internally. But external conversations are about saving this life-saving program, Medicaid. But then soon we are going, when better times come, and I'm talking not that far in the future, we need to seize the moment, seize that opportunity. And we've seen this in the past. Remember in 2018, we saw that that the Affordable Care Act was under attack, and there was a huge people power movement to save the Affordable Care Act. And people fought, and there were sort of 6 official attempts to kind of repeal it, and we actually won. And then we saw that Medicare for All as a policy conversation was at its all-time popularity. And it's been discussed for a long time. Basically, since Medicaid was created, we were talking about a kind of universal healthcare system. But we actually had some real advancements, if you remember, in the candidacy of Bernie Sanders. So we know that we can fight now if we organize people, and the people who are Medicaid recipients, they will fight to save their healthcare, and then they will also help guide us into the changes. And there are real policy things that we can start to think of. Having those folks at the table to decide what those changes in the Medicaid program or whatever universal healthcare expansion of healthcare program that we have, that's government funded, where no one is thrown off. We know for sure we'd get rid of things like work, any kind of requirements to come in and recertify, and work requirements, because those are always and have always been just a way to kick people off of Medicaid or any of the benefits that are given. So if you are a service provider, invite organizations, advocacy organizations in to talk to your clients. If you are a Medicaid recipient, join with others to fight to tell your story of how important Medicaid is, and then stick around in just a couple of years when we have this opening and we can actually bring everyone together to talk about how we can strengthen the program.
Anton, could I jump in for just a second here?
Yeah, please go ahead.
I just want to build on what you're saying, Jennifer. I think that's so right. And right now, as problems emerge, it's so important to get those problems into the public conversation. The folks who are on this call, I see almost 900 people. You all are going to see disasters walking in your door. And it's so important to tell the story of what you're seeing, talk to reporters, spread it on social media to your friends and your family. The most important thing, if people know what's going on, the public will be repulsed at what's happening. And we need to just really educate people about the disaster that is unfolding. It's starting right now. It's starting right now with most of the Medicaid cuts were, not by coincidence, delayed until after the next midterms before they take effect. But the ACA cuts are happening now. The SNAP cuts are happening now. And when you see something, say something. When a problem walks in the door, talk to a reporter, get it going on social media, tell everybody you know. We have to educate the public about what's going on.
Great. Thank you, Stan. I actually have a few more questions for all of you. This is a great conversation so far, learning a lot. I know we're sharing a lot. The chat is on fire right now. But here's what I want to do. I'm going to pause this conversation for 1 minute, and we're going to share a poll, okay? And we need to know if you plan to stay for the breakout groups. Of course, We want you all to stay and meet up with peers and be involved in the conversation. But we need to have a sense of how many people plan to stay. So that helps us to plan how many breakout rooms that we need. So if you could answer the poll question right now, that would help us. And remember to continue to add your questions for the panelists into the chat. So we'll give you a half a second to do that. And I see Jade, you're planning on staying. Just make sure you answer the poll. The breakout rooms, again, for you to meet people, have conversation with people who are doing this work. We like to build community as a part of the intersection. So the breakouts are the opportunity to go deeper into this, is really to have further conversation and have some framework. So we'll give you, and we're going to finish right at 2:00. So don't worry about this going too long, but we'll have some brief breakout sessions to give you a chance to meet people and then go deep. Okay. And keep adding those questions. I see them coming in. I want to ask some more. So Deanna, I want to go back to you because you're really on the ground, and Georgia's a part urban state, a part rural state, and there's some other states who don't have their work requirements coming yet, or they haven't started this process. So if I'm an advocate on the ground in the state that know this is coming, what can I do to prepare for these upcoming changes? How do I help people, and what could you share with other advocates to help them to be prepared to respond to the changes that are coming?
Okay. To prepare for those changes, my first take will be utilize your official resources. With us, we have Department of Community Health, and they provide guides and toolkits with helpful information about the program and its website. Now, if you are unsure how to contact your Department of Community Health or Health and Human Services directly, you want to reach out to them to make sure you have the accurate information. Now, if toolkits are not available, please speak with your organization or partner organizations to create branded material to share. This is going to be the biggest part of your community outreach. Outreach and education is how people are aware of the changes and let them know how to prepare for those changes. So you would need to participate in community events and do some canvassing. You have to go where the people are. People are at church, people are at food banks, people are at schools, libraries, shelters, community and resource centers. You go there, you provide flyers, application assistance, and renewal reminders. One of the biggest things now is digital outreach. Make sure you're promoting on your social media platform. They need to see it, hear it from every aspect that they can. One big thing I would say is make sure you verify with your state if there are enrollment and renewal assistance available to provide hands-on help. We have navigators and certified application counselors and other community health workers who help clients to apply and complete renewals. In those departments, you do want to hold your state accountable to ensure that their department that's processing those applications, that they have the capacity to complete them in a timely manner. Most of the Department of Family and Children Services are understaffed, which leads to delay in processing applications, which ultimately leads to delay in care.
Yeah.
I would say start early recruiting for those positions and filling those positions to make sure that department is available. And one of my biggest challenges would be prepare for the transition. Unfortunately, we know there are going to be people who are going to lose coverage. So we need to make sure you have a bridge to other programs. Provide information to help those who are losing Medicaid coverage to transition, whether it's to an ACA market plan, local health programs, the health department, or sliding scale clinics. And also I want to add, please educate your clients on their rights. They need to know that they have the right to appeal a decision if they feel they're wrongfully denied or terminated, and that there's help available. In Georgia, on their notice of decision, when they are denied or approved, they have the option to file a fair hearing. On that option, they have free legal services that's available to help them. So we have Georgia Legal Aid, Georgia Legal Services Program, who will help them through the process of filing a fair hearing.
Wow. You laid out a lot of great things that people should be taking stock of and trying to line and put together now to be responsive to the changes that are coming. Laura, I want to jump to you about coordination around all of this and what lessons you could share about coordinating between state agencies, because sometimes you may not have everything all in one agency, but you got to coordinate between state agencies and community partners and other advocates to make the work requirements process smoother for people to be able to keep their coverage or get the coverage that they need? Any lessons you can share about the coordination process and what people should be doing in other places?
Yeah, absolutely. As folks can tell by the timing, our work requirement program rolled out in the midst of the Medicaid redeterminations or the Medicaid unwinding process in 2023. And so um, we, along with other partners, convened a very broad coalition of stakeholders, and that would be incredibly beneficial in other states. So you should think about both the agencies that are that your Medicaid agency, as well as if it's a separate agency that determines eligibility, inviting them to be part of that coalition, healthcare providers, whether you're an FQHC or otherwise, financial assistance representatives at hospitals, community health workers, enrollment assisters, SNAP advocates and stakeholders, because there will be expanded SNAP work requirements as well. And then other stakeholders that are part of the safety net and that either support or employ low-wage workers and low-wage individuals. This coalition can be incredibly powerful for doing many of the things that we've talked about across the panel today. They can help to shape advocacy for the policy changes that are needed at the state level to make this as smooth as possible. They can create and share educational materials. They can help refer people to each other for enrollment assistance. They can elevate those cases or stories that need to be troubleshooted or highlighted in the media. You can also collect and publish data about applications and processing times, denial rates, other key metrics. So that coalition can be really powerful, especially if you kind of delegate and use everybody's strengths as effectively as possible. And as Deanna said, it can be incredibly powerful for holding our elected officials and state leaders and systems accountable for the failures and gaps that will inevitably appear as part of the implementation of work requirements. So having that coalition ready to go now and working ahead of the rollout is just incredibly important.
Very good. Well, definitely thank you for sharing. Stan, I want to come to you real quick. And, given the ongoing cuts to navigator funding and language access, how can, state leaders, federal leaders better support community groups that are filling those gaps? I'm really talking about what can, we do to make sure we support people on the ground and community organizations to fill the gaps that now exist because the funding is gone away.
Yeah, it's a great question. Couple things. One is philanthropy has an important role to play in filling gaps. I mean, now I know these are tough times for philanthropies like everybody else. The needs are so enormous and the resources are not infinite, but nonetheless, there's an important role to play. Second, if you're in a state where the state government is supportive, the state can do a lot in terms of putting dollars on the table, drawing down federal matching dollars, maybe taking foundation dollars and leveraging that for federal match to provide assistance to people. Look for resources wherever you can. It's very tough. But I think Laura really put her finger on the things that we need to be doing. State policy advocacy, community education, and public information about the scope of the disaster and the problems that are happening. Looking in the chat, people talking about how can't get through on the phone, can't get through online, can't reach a person. Talk about that in the media, make that an issue. It's not okay. Our tax dollars pay for government services. It's not okay to have terrible customer service for the agencies that are supposed to serve us. So that's not you can't conjure money out of nothing. We're in a tough spot right now, and we just have to take what we can and leverage it through policy advocacy and put political pressure on in the media to try to get pressure for improvements. And it can work. I mean, in Florida, for example, as I mentioned, our state office has been putting pressure for the call center. Terrible wait times. Wait times have come down. Even in states where things seem hostile, people want their government to work at a functional level. So I think we got a lot of work to do. But I think Jennifer's exactly right. This is an opportunity for us to educate the public about the disaster of the system that we have now to lay the groundwork for a better day.
Wow. Well, thank you. I appreciate that. And Jennifer, I want to bring you into this because, I'm curious about the public's opinion about all of these changes. And what do people actually know? And number two, they know that the changes are coming. Are they popular? What's the public opinion information say about what's going to happen?
Yeah, well, I called it before wildly unpopular to take away people's health care. And that is true. A recent Kaiser Family Foundation health tracking poll found that 83% of independents, 74% of Republicans, 93% of Democrats, we view Medicaid favorably in this country. And the same poll revealed that 72% of adults are concerned that cuts to Medicaid funding will lead to loss of health insurance for individuals and families. Something that is, I think, helpful for us is that at this point, all of us, no matter what our engagement with the public assistance system has been, we all now have experienced, particularly healthcare, our health insurance programs, giving us the runaround as a way to cut services to us. We know that. That's deeply ingrained in us. And frankly, we know that all the corporations are doing it. Our bank gives us the runaround, to take $5 here from our checking account and, as they shift it into our like savings account or something. We know that that's happening. And that actually is kind of new. Like in the old days when welfare reform policies came in, a lot of people didn't really buy that this kind of runaround when you go to like recertify, that was intentional to harm you. That, it seemed to make sense. Sure, of course. Why shouldn't you just go there? We're giving you money. You go to the office. And what do you mean they're not answering phones? But now we're like, of course they're not answering phones. If I have to call, Con Edison, I know that's an all-day endeavor for me. I'm not going to get through. So
Yeah.
that it's an opportunity that people know that these are wildly unpopular when you talk about taking away healthcare. And that's how we should frame it. Someone not answering the phone is taking away your healthcare. And we have a big job though, to make sure that people know who did this to us. Because unfortunately, if we just say, oh, Medicaid sucks, then that's a crack. And the crowbar that the other side has is huge, and they will barrel through it. It's a jackhammer. They'll jackhammer through it, and they will say, yeah, we agree. Medicaid sucks. Let's get rid of that whole program, and let's create a new healthcare system, that we call like Trump healthcare or whatever. And that healthcare system is going to be terrible for all of us. I think everyone who works in healthcare agrees on that. So it's unpopular, but we need to make sure that we are sharing the information about who did this to us and exactly what is happening. And what is happening is that they are taking away our healthcare.
That's great. Well, I got one final question that I want to get some feedback from everybody. We like to leave people thinking about change in the right way, improvement in the right way. So my question, and I'm gonna start with you, Laura, and then I'm gonna go to Jennifer, and then Stan and Deanna. I want you to close us out. Is if you were in charge, and how could we redesign Medicaid so it's less shaped by structural racism and more responsive to the needs of all communities? So what could we do to redesign? So I want to kind of paint the picture of the future, that change is coming, and we want it to be good change. So what can we do to make it less structurally racist and more responsive to the needs of the community? Laura, I'll start with you.
Yeah, I was reflecting on this question yesterday and today as I was making and finalizing my notes. The PowerPoint slide that I sometimes put up in front of groups that demonstrates kind of who is eligible for which types of Medicaid at which income levels, and it's a stacked bar chart that I also that I have to make in Excel and then adapt with some additional details because this system is so incredibly complicated. And that's just like one little PowerPoint slide, right? That doesn't really matter. It's not actually important to anybody's life, but it kind of demonstrates how tricky the system can be for people. And so I think my most general answer is to simplify the eligibility requirements for Medicaid. Everybody in this country should qualify for some for quality, affordable health coverage. Medicaid is that, and we should make it easy for folks to qualify. by simplifying those eligibility requirements.
Very good. Jennifer, how about you? What can we do to make it
Yeah,
better?
thank you. Simply put, everyone's on the same system. Decouple it, our crazy system, coupled to our employment, that makes no sense. Everybody's on a Medicaid. And, that way it impacts everybody the same. We're all invested in saving it. I think that also communities should set up a review process that has community members who, are the highest users of the healthcare system, who are at the forefront of reviewing how it's going and decide, should changes be made.
Very good. Very good. Stan, talk to me.
Three
What can we
things.
do for
Three
redesign?
things. Number one, radically change eligibility rules so you don't have to fill out paperwork to get coverage. The government already has a lot of information about us, way too much, but it does. Let's redefine eligibility so that based on the information the government has, they automatically qualify. You automatically get health care. Two, give beneficiaries the right to go to court and hold states accountable for breaking the law. The Supreme Court has said that you can't generally do that. Well, that's just the way the statutes are written. Let's change it. And three, write into the law a disparate impact standard for civil rights laws. So right now we have this thing, Title VI. If you get federal dollars, you're not supposed to discriminate based on race, national origin, other things. You can't go to court unless you can prove intent. Well, very hard to prove intent unless people are really stupid. So there's a disparate impact test that's been used with the regulations, but you have to go to the agency for that. Ain't happening with the Trump administration. And even with the Biden administration, they didn't have enough resources. So we need to change the statute so that if there's any policy that has a racially disparate effect that cannot be justified as necessary to achieve a compelling interest, that policy can be enjoined by a private person who's harmed. So those are the three things that are at the tops of my list. Radical changes to eligibility, so data matches, not paperwork, qualify people, give beneficiaries the right to go to court and hold state agencies accountable for breaking the law, and have a disparate impact test that gets codified into federal law with a private right to action. Oh, and I see people about trusting federal data for eligibility. Yeah. When the data goes to the feds, it needs to be de-identified so that it can't go to ICE. That's a huge problem. We could talk another hour and a half about that.
Right. Yeah, we sure could. Sure could. Deanna, from your perspective, as someone who's on the ground, and again, Georgia's 159 counties, it's a big old state. A lot of people need access to Medicaid, as we heard at the top from Jamila around it. So what would you recommend to make the system less structurally racist and more responsive to the people who you interact with on the ground who need the Medicaid program? What changes would you recommend?
Okay, I have to start out this way since I'm in Georgia. Expand Medicaid. It shouldn't have been an option. It should have been a requirement. So we're in the last of the 10. But also just removing those hurdles. You can't make it seem like Medicaid is a handout if you're making people jump through hoops to get it. Stop making them feel like they're at the circus to get health care when this is something that's necessary. I said just removing the work requirements and qualifying activities and not make it so hard. It should be easy to get assistance from a state agency that our tax funds pay for. So we should have access to the people who are responsible to process that for us. One of my biggest things working in the field and noticing is avoid using punitive tones. You make people feel bad when they need to apply for these services, which kind of hinders them from applying. It shouldn't make them feel bad that they need help, whether it's for SNAP, TANF, WIC, or Medicaid. Make sure that beneficiaries should be encouraged to apply for these programs and that help is available.
Wow. Those are real, those are tangible, those are, straight up do it now. And I heard you talk about Georgia being one of the 10 that hadn't expanded. I'm in one of the 10 too. I live in South Carolina, and it's also an incredible challenge right here. So thank you for that. You all have been phenomenal. And I would be honest with you, we probably could talk all day about this. And so I want to kind of bring us to a close and get ready to transition us to breakouts. But before I do that, I want to ask each of you, with all of the challenges and all of the change that we're dealing with, I want to see if you can boil it down to one word of what you see as possible in the future? Or what do you feel about the future? I know you're in the midst of it. Everybody's in a different space and you're working on it. But I'm just trying to leave our audience with some sense of thought around what the future may look like. So if you could boil it down to the one word, what you hope for in the future as it relates to Medicaid, access to healthcare for those who need it. I want you to give it to me in one word. And Stan, I'm going to start with you first.
Learning.
Learning.
Let's learn from what's about to happen.
Very good. How about you, Jennifer?
The website version of Medicare for All. Then it's
Very good. Deanna, how about you? One word.
I have to say hopeful. I have to make a statement with that because keep in mind our state noticed some of the things that were not working and implemented changes. Just as an example, reporting went from being on a monthly basis to being during your application and then during annual renewal. So definitely stay on top of your state agencies because it's possible for certain changes to occur.
Mm-hmm. Okay. And how about you, Laura?
Uh, m- People at the center. I know that's 4 words and not one, but just putting the Medicaid member at the middle of the system and at the priority of the system.
Yeah, very good. Well, first, I want to say thank you to Stan, Laura, Deanna, Jennifer, and Jamila for being here and sharing insights today. It was a powerful conversation. For all of you who joined us, we hope that you stay connected at the intersection. Sign up for updates at meetattheintersection.org. Please follow our LinkedIn page and, of course, subscribe to the podcast on Apple, Spotify, or Amazon. We now invite you to stay for the breakout groups. If you can't stay, we understand. Please exit promptly. We appreciate you leaving promptly so we know how many breakout groups we expect. We'll expect on the back end, and we'll transition to breakout groups in just a moment. I want to thank you again for being here at the intersection. Everybody have a fantastic day. And for those in the breakout groups, we'll see you shortly.